Hi, everyone. So great to see so many people here this morning, or I guess in the evening if you're on the other side of the globe. So just wanted to start off by introducing our speakers today. So first I'll introduce Dr. Bach, who I had the pleasure of working with this summer on my GSTDP project. So Dr. Bach is an assistant professor of pediatrics at UCLA, and he's also the director of the UCLA Mozambique Academic Partnership. He works a lot with UCLA medical students and residents who are interested in clinical as well as research rotations in Mozambique. So if you are interested in the work that he does in HIV and TB, definitely feel free to reach out. I had a great experience learning from him. And so I'll then go on to introduce our next speaker, and we are really, really grateful to have Dr. Maria Inês Deus with us today. She has a degree of medicine from the Faculty of Medicine at Eduardo Mondlane University, and then she did her pediatric training at Maputo Central Hospital, and then did a master's degree in HIV and health management from the Catholic University in Mozambique. And so she has more than 15 years of experience working in the Mozambican healthcare system, and she currently serves as a pediatric treatment specialist with CDC Mozambique, in addition to her work that she does with the Ministry of Health to develop guidelines and programming around HIV and TB. And TB, specifically focusing on pediatric HIV and PMTCT, or preventing mother-to-child transmission, which we are going to hear about more today. So without further ado, Dr. Bach, Dr. De Deus, please continue. Thank you.
Thank you very much for the introduction, Emily, and nice to see several faces that I already know and a couple of new faces here. Thank you guys all for joining, and Dr. Miller, always great to have you here. For those who don't know, Dr. Miller is kind of my supervisor and mentor, one of them at UCLA, so always nice to have you here. Thanks, Lee. You know, it's interesting, Maria, Nesh, and I essentially have kind of swapped places. When I came to Mozambique, I was working at CDC as a pediatric advisor, and now she's in that role. And she was doing her clinical work, and now I'm more clinical. So I think we both have good experience on both sides of the table. And for me, you know, as an American who's, you know, came to Mozambique to work, I've really relied heavily on my in-country colleagues to just help orient me and make me understand things that go beyond the clinical or the epidemiological. You know, HIV in particular, much a disease of the society as it is of the individual. And what we hope to do today is delve in a little bit to that with you guys and look at, you know, some of the biomedical aspects of mother-to-child transmission of HIV, but also hear from Maria and Nesh about what are those unique cultural and societal factors here that are complicating our efforts, and why do we still have so many babies who are being born or becoming infected with HIV during breastfeeding. So that's our goals, and our session is set up where I'm going to review a little bit of slides, a few slides for each section, and then I'm going to pose a question to Maria Nesh, and then she's going to kind of respond freely, and we welcome questions, you know, in each break so that you guys don't have to save all your comments or questions to the end, okay? Cool, so let me try to share my screen here and we will get going.
Hi, Chris. Just to say that I turn off my camera so my internet bandwidth it's become a little bit better. So apologies for that.
Okay, no problem. Maybe when it's your time to talk, we can turn it on and see if it works, but no, we know you're here with us. Thanks, Minesh.
Okay.
Can everybody see my screen? Yeah, I put it in slideshow view.
We're good.
You got it still?
Yeah.
Thanks, Lee. Okay, guys. So yeah, we're going to talk about social determinants of health and PMTCT in Mozambique. So what I hope to cover with you guys today is I want you to understand what are some of our key strategies, interventions for PMTCT. We can do some reflection on what are our progress towards the goals of elimination. They call it EMTCT, of Mozambique and of HIV in Mozambique. And unfortunately, we're quite a ways away from EMTCT. And then we're going to delve into what's unique about Moz and why are we having these challenges. So those are our 3 learning objectives. And this is the global epidemiological context. So this pie chart shows you the distribution of children who are acquiring HIV in some of the kind of priority high prevalence countries in the world. And we're in a very bad position here. We're at 14%. We're the country only behind Nigeria because of the vastness of its population. We're producing more new pediatric infections per year than countries with populations that are much larger than ours, like South Africa, and that has an HIV prevalence that's higher than ours or similar to ours. So if you compare South Africa and Mozambique, what you realize is that it is possible new pediatric infections in a high prevalence setting if your PMTCT program is functioning well, but we're not achieving that right now. And then this is a figure that estimates, and it's a little bit outdated for Mozambique, but it estimates what is the rate of vertical transmission of HIV from mothers to babies at 6 weeks of age, and then the final transmission rate in some of these focused countries. And this was in 2019. And you can see here that Mozambique, they estimated that 6% of babies who were born to mothers with HIV had confirmed infection by 6 weeks of life, and another 8% acquired HIV during the breastfeeding period. And so these are different patient populations with different interventions that we use to try to prevent. But this is, really unacceptable. When you look at some of our regional neighbors, you can't say, oh, it's a uniquely African problem, because there's countries like Malawi that shares a border with us and has a similar socioeconomic profile that has an MTCT rate of 6. So what is it that's kind of really holding us back? We want to explore that. And this graph here just shows that, in fact, we still are having a lot of new pediatric infections. I will say that this was done in 2019. And one thing that's happened since then is we've introduced a new regimen for adults and pregnant and lactating women that involves the antiretroviral that's called dolutegravir. And I haven't seen, big studies or epidemiologic data to confirm this, but anecdotally, I can tell you that the introduction of this new drug is having a big impact on vertical transmission, because I see fewer babies in the hospital every month with HIV. So Maria Inês, in her role with CDC, might have some updated estimates about what vertical transmission is in the country, and I'll let her speak to that. So today, as we go through this talk, we're going to kind of look at 4 pillars of PMTCT. And so this is like the kind of international community, WHO and UNAIDS and others who have been working on this, try to identify different time periods in which there's vulnerability along the entire cascade. And historically, we've often thought of PMTCT as like the provision of medicines to mothers and babies to stop, transmission, but it actually starts much sooner than there. And we can talk about primary prevention and other things. So let's talk about that. Why are young women in Mozambique acquiring HIV? There's a big gap between boys and girls or youth, young women and young men in terms of HIV prevalence. And this is true across the region. There's biological risk factors. Young women, the transition zone on their cervical mucosa has more columnar epithelium, which is a risk factor for HIV acquisition. There's a ton of socioeconomic risk factors, and I won't get into those because that's Maria Inês' job to discuss those, but there's a gap between men and women. This was a survey that was done a few years back that illustrates that there's really low levels of knowledge and low use of regular use of condoms, which we know contributes. And if you can look here at our track record over previous 5 years, very little progress was made on reducing HIV incidence in young women. These were 2 interesting studies that were done in a province in Mozambique called Gaza about 5 years ago. And they recruited women who tested negative at their first antenatal visit. So they were pregnant women and tested them serially every 3 months. And what these two studies combined showed was that these young women had approximately, this population of young women rather, there was an approximate 3 to 4% rate of serial a year. So part of the problem is that, you know, the young women are incredibly vulnerable to acquiring HIV. And when that happens, they often don't know they have it and are therefore going to pass it to their babies because we're not intervening on that. So this has probably come down a little bit since the time of these studies because we've really scaled up antiretroviral treatment across the country. And hopefully that's driving down incidence, you know, kind of at a national level. But a lot of the new infections, including a baby I'd just been taking care of all afternoon today, was exactly this situation. A mom who tested negative in antenatal clinic, she tested negative in maternity, and the baby showed up today in the hospital with severe pneumonia and thrush, and both she and the baby tested positive today. So it's a real problem. So with that, we talked about the epidemiologic profile, and we talked about pillar 1, which is primary HIV prevention in young women. And so, Maria Inês, my question to you and to the students who are here with us is, what social factors do you think might explain this high risk for HIV transmission in young Mozambican women?
Does anyone wants to go first? Any ideas?
Something that immediately comes to mind for me is I guess an inequity in that may be like gender based with regards to how folks are able to access sexual health care and how that may be stigmatized differently for women than men.
Okay. One more thought.
I think going off of Nafisa's comment, I think also like young women especially probably have less like power when it comes to negotiating like safe sex practices, like using condoms. And then I think that also could really, you know, be part of the explanation for the disparity.
Yeah. You both absolutely right, Nafisa and Emily. In a country like Mozambique, we've saw very low education level and low health literacy levels among young women. It is very difficult to transmit to them the need to access the health facilities. And the social economic factor also have a very big impact. They need to have permission from their parents, from their husband to be able to access the health facilities. So that's a very, very big barrier. They will also need they are not able to disclose their HIV status. They don't have the support from the family to access the services and to access the PMTCT service since the beginning of their pregnancy. So that's why we still have very high vertical transmission rate. In the north part of Mozambique, we also have that cultural aspect that women should stay at home and find a husband early on that can sustain for the family, for themselves and for their families. In the southern part of Mozambique, we have a different scenario, but women are also expected to have children and stay at home, and they are kind of forced to have multiple partners to be able to sustain themselves. And some partners are migrant workers to South Africa, neighboring countries, and all those factors contribute to the women to not have a very strong decision power and to not have the adequate health literacy level to seek for healthcare service as soon as they find that they are pregnant.
Inês, can you speak to how families prioritize education when there's multiple children?
Yes.
And And are girls often on the underside of that when families have limited resources and who they choose to educate?
Yes, unfortunately, what is happening in Mozambique is that boys are prioritized over the girls. So when a family is poor, they prioritize, they put everything that they have together to prioritize the boys to go to school, and the women stays at home, and they are encouraged to marry early and find a partner that can sustain for her and for her family. So because of that, we are continue to see, how can I say, early marriage. Yeah, is still is still a reality in our country. Early marriage, childhood marriage, and the women in that kind of situation doesn't have the decision power. They need to ask permission for their husband to seek the healthcare services or from their mother-in-laws. And when she gets the chance to access the service, she gets the chance to be tested, she feels afraid to disclose her status, her HIV status to the family, to the mother-in-laws, to husband. She feels afraid to send out of house and to be accused of bringing the disease to the family. So normally she stays quiet and keep the secret of the situation for themselves. So this constitutes another challenge for her.
Thanks, Minej. And often that ends up with young women often being in relationships with older men too, kind of going back to Emily's comment about kind of difficulty negotiating safe sex and other things. Could you please tell the students a little bit about the DREAM program and what PEPFAR and CDC are doing in terms of primary prevention for young women? Yes,
because as Chris was mentioned, in PMTCT cascades, we have the 4 prongs of the PMTCT cascade. And the first prong, the first pillar is prevention. We need to prevent young women to get infected of HIV. And then if she is infected, we need to prevent the transmission to the baby. So the DREAMS program that is supported by PEPFAR in Mozambique tries to put together a series of activities that allows young women to have access to information, not only specific about HIV, how it's transmitted, how can be prevented, and how, if infected, how can we stay healthy with HIV, but also talks about health literacy in general. So we can educate young women since the early young age how to become healthy, how to improve their nutrition, how to become a productive society member, how to generate income for themselves. So this also can reduce their vulnerability to other risks, such the need to find a husband so early, the need to have engage in transactional sex, or to have partners to provide to fulfill different needs, someone to pay the school, someone to pay for the food, someone to pay for something else. So this DREAMS program as is being implemented in some districts in Mozambique to give the chance to these young women to get the knowledge, to prepare themselves and to reduce this vulnerability. The program select ambassadors, DREAMS ambassadors that are role model young women in each community that are trained and educated to be able to speak for other peers. So it's a peer-to-peer activity. So it's not a medical doctor like myself going to a district and talking to the girls. It's a girl from the same district talking to other girls at the community, at the market, at the church, at the school. So this interaction, we think that is more powerful. Thank you.
Thanks. One time a friend of mine asked me, if you had a huge chunk of money and you wanted to do something, a single thing to impact the shape of the HIV epidemic in Mozambique in the long run and not in the short run, what would you do? And I think my answer was that invest in young women. And the fruits of those investments are going to take time. But I think a lot of us who've been working this for a long time realize that if we don't focus on the earlier part of this cascade, that we're always going to be behind the ball. So, we could spend the whole time talking about this particular part, but I want to move on to the next pillar. And let me see if I can get my computer to cooperate here. So there you go. Are you guys still seeing my screen?
Yes, please.
Okay, so yeah, now we're going to look at the next step in the cascade, which is trying to prevent unwanted pregnancies in women where we failed in step one. So a woman has HIV, but she might not actually want or desire to be pregnant. As Maria and Nesh mentioned, there's often a really strong social pressure and family pressure for young women to have babies in this part of the world. And so often, one of the challenges we face is people actually desiring pregnancy regardless of their serostatus. And certainly everybody has a right to have a family, regardless of their HIV status. But here's some data that can help inform this discussion. And so this was a survey that was done by an NGO here called ThinkWell. And they looked at the graph on the left shows the number of health facilities that have these different anti-contraceptive contraceptive methods available rather. And you can see that for some things like Plan B, the availability is not ideal, but 94% of all health facilities in the country at least offered some method of family planning. And then this graph here on the right shows the percentage that have services that are deemed adolescent and youth friendly. So the dynamics of providing family planning to a young woman is often much different than an older woman. And there's a lot of paternalism or maternalism towards younger patients. But you can see that we're not doing as good a job at equipping health facilities to promote family planning and provide family planning to this particular risk group. So that was a briefer part on my end, but Maria Nesh, my question to you then is why is there low uptake of family planning services even when they are readily? And maybe you might want to start with some hypotheses from the students again.
Okay. Yeah. So anyone want to guess or to start to provide an opinion about this?
I can start. So I feel like it's probably a similar narrative in that there's a lot of stigma about seeking these services, various forms of birth control, and also if after sex, like going for Plan B could also be very stigmatized for women. So that's something that I was thinking about.
Something else? Okay.
This might be
So-
kind of off. Oh, I'm sorry.
No, go ahead, please.
Is there also I think it's social stigma, but also like a religious component to using family planning services in Mozambique? Like, if it's majority Catholic, I don't know the religious kind of breakdown, but that might be something else that would, make a woman less likely to use those services.
Okay. So as we mentioned before, it is expected that the role of the women is to have children. So culturally, we have that pressure to start a family as soon as possible. And even if it gets worse if you comes for a poor family, the pressure is higher. But Sharon mentioned about the social stigma. When the young women have the chance to have the information that she can seek the health facility to get family planning services, the problem is that when she arrives at health facility, she will be seen by an elder MCH nurse. She will be sitting in the same waiting room for elder women, and she can also be close to her aunt, to her mother, or to someone elder from her community. So this social stigma, it's very high. Unfortunately, in Mozambique, our coverage of services for youth, for adolescent and young women's youth-friendly services is still very low. We have near 1,015 health facilities, health facilities in Mozambique, but our coverage for specific service for adolescents and young people, it's less than 50%. So we still are in the earlier stages of creating friendly services so that every adolescent and every young woman who wants to start a sexual life, who wants to have access to family planning service, can easily go and be serviced without the fear, without any stigma, and she can feel comfortable. So we are still working on that. And for this current fiscal year that started this month, we are planning to introduce a new community health worker cadre that it's called adolescent and young peer mentor that will work directly with these young women and young population overall, young men as well, to educate them where to go, where to access the health facilities, and try to help them to navigate within the health facilities. Because the problem is not only the access, and the problem is even when you get access, how could you be better served when you reach the health facility? One of you mentioned the religious culture in Mozambique. We have kind of 50% Catholics and also Muslim population in our country, and both of them have very strict rules about how to do the family planning, how to plan your family, and to have children or not. They strongly advocate to have children. So it's also a very, very big cultural aspect, religious aspect that young women in Mozambique have to face to be able to reach the family planning services.
Thank you, Maria Inês. And I have one more question for you on this. You know, we're talking about women who have already failed Pillar 1, they're HIV positive, and we want them to have access to family planning services. How good a job are we doing in Mozambique of integrating HIV care and family planning such that a patient could get both at a single visit to the health facility by a single provider and not have to, get those separately?
Yes, that's a very good point. Commonly, the family planning services are within the maternal and child health care services, so at the MCH services. And in our country, they are offered in a consultation that we call it at-risk child consultation, where normally we see the children at risk, and we put together in the same consultation risk the breastfeeding women that comes to receive the family planning services. So imagine if you already have are HIV positive young women. First, you will need to go to the ART consultation, then you need to go to another consultation room in the same health facility, start a new queue in the family planning service to be able to access the family planning. So to avoid that and to try to minimize that, what we did, and it's a program that started more or less 5 years ago, was to train all the providers that are providing HIV clinical care to be they are able to provide also family planning service, at least the very basic family planning service, the condoms, the pills, and if they are not able to provide everything on that same room, they can at least provide counseling to the young women and refer them to the family planning service at the maternal child health care. So this is a strategy that is in place. Every clinician that provides HIV care should be trained on family planning so they can offer the service, educate the women, and if there's something that we cannot provide at that same consultation, they can easily refer to the MCH nurses.
Thank you so much, Maria Inês. Emily, are we doing okay on time? I know we're kind of integrating the discussion as we go along. We have to the end of the hour, right?
Yes, we're doing great.
Cool. So guys, let's turn our attention to the third pillar. And the third pillar, when people talk about PMTCT, this is what they're often thinking about. It's the kind of biomedical part of it, where we're giving antiretrovirals to prevent or to treat. And honestly, like myself and others who are medical doctors, this is the part where we spend the most time on. But if our colleagues who are working in the maternal child health sector, if they're not doing their part in terms of primary prevention and family, promoting family planning, then pillar 3 becomes a lot more difficult. So for you guys, I'm sure you guys are all aware of this, but HIV transmission from mother to baby can occur at any point during pregnancy and lactation or breastfeeding. And some people say, so the woman, it depends a little bit on when the mother acquires HIV, but assuming the mom has HIV at the time she becomes pregnant, they think that approximately a third of the transmission will happen in utero, a third will happen in the peripartum period, and a third through breastfeeding. That number, I think, is changing over time because, as I mentioned before, we're having women who have incident HIV during, they have seroconversion during this time period. And women who are already have HIV when they become pregnant are often in care and hopefully, on an effective care and have to suppress viral load. But these are all periods of risk for transmission. The cornerstone of a PMTCT program is testing. You have HIV positive women before you can intervene. And this is an area where Mozambique has done an excellent job. These graphs are in Portuguese, but this says the percent knowledge of serostatus in pregnant women in antenatal care. And so you can see here that across the different provinces, from 97 to 100% of women who went to their first antenatal appointment, they were tested for HIV. So we're doing a really good job doing the first test. These are some of the provinces here that have a higher HIV prevalence. I'm trying to see here. And these are some of the, so I put these little bullets in here. I'm remembering from the past presentation, from a programmatic perspective, if you weren't doing clinical work, but you were trying to run a program at the ministry level, you'd have to think a little bit, if you have limited resources for PMTCT, would you focus more on provinces that have a lower volume of pregnant women, but a higher prevalence? Or would you put more of your eggs in the basket where there's a lower HIV prevalence, but a higher antenatal volume? And that's a debate. Inês and her colleagues who work for PEPFAR have to decide how to split up the donor funds. And so I know they have a lot of interesting discussions every year when they're doing their planning about how we should prioritize our interventions. This is an interesting aspect, and this looks at HIV testing of male partners when women go to antenatal care. And it's a busy slide, but I want you to pay attention to the green line here, which is the number or the percentage of partners who were tested. So you can see the highest is here in Nampula province, which is in the north, where the percentage, I think, approached 90%. And so remember, those provinces where I said have high volume of pregnant women, a high dense population, but lower HIV rates, they're doing a good job. And then here in the southern part of the country where prevalence is high, male engagement is really poor. And you can see how few of the male partners were tested. So that's an important challenge, because if you're not in a situation to be able to disclose your HIV status to your male partner, imagine how difficult it's going to be for you and your baby to take the medications necessary to kind of try to prevent prevention. This graph is to let you guys know that it's been cool for me, to have chosen to work in HIV in my career, because it's been so dynamic, and just about every year or two, there's new guidelines and new evidence from WHO and from really sophisticated international research that's taught us more and more how to manage disease and how to prevent disease. And so, we went from a period of time where we were giving a single dose of nevirapine to mothers and babies around the time of birth, to starting to use dual prophylaxis. And then we were something called option B+, where we started recognizing that full treatment for women and trying to suppress their viral load was the best way to suppress, to reduce vertical transmission. And now we're in the era of test and treat for everybody. That's been the norm in Europe and the US for a long time, but because of resource limitations and capacity limitations, we weren't there for a long time in Africa, and we had to wait and prioritize those who had more advanced disease. But fortunately, we're testing and treating everybody now. And really underline the whole idea of U equals U. And if you're on treatment and your viral load is suppressed and you're undetectable, you're essentially untransmittable. And that's whether you're talking about your sexual partners, if you're an IV drug user, it's the people you share needles with, and if you're a pregnant or breastfeeding woman, it's talking about your baby. So that's where we want to go. We put a lot of effort in getting our pregnant and lactating women to you. And so, once they're identified, we need to treat them. And this graph shows the progress we've made in the country from transitioning from a period of time in yellow, when the majority of women were receiving prophylaxis, to now where almost all the women in the country who are positive are receiving full antiretroviral therapy, the most efficacious intervention we have to suppress their viral load and prevent transmission to their. So this is an incredible amount of work, because to get to that number, we had to push ART out from specialized centers with more higher level healthcare providers to the most rural small posts, and train, all the nurses who work in those posts to be able to provide antiretroviral therapy. So we're very proud of that graph here. But this is a unique challenge and something I hope Maria and Nash will explore with you guys, but we're doing a good job identifying, we're testing. I showed you we had a good looking graph, and initiation, we have a good looking graph, but our retention graph is ugly. So this shows dropout of mothers and babies during the entire cascade, from the time the mom's tested to delivery, to the child showing up for the postnatal exposed infant clinic to get their first HIV test. And so this isn't true just in the PMTCT program, but also in the national ART program. Mozambique has challenges that we don't see in a lot of the other regional countries in terms of really poor retention. And Maria and Nesh might have some insight into that. And the end result is that, and I referred earlier to that graph that showed when babies are becoming infected in Mozambique. So this is different data, but it shows something similar, that, there's a fair amount of babies who are infected before they come to get to 2 months age. But, problems in retention are also contributing to pediatric infections during the breastfeeding period. So, Maria Nesh and students, what social factors do you think might explain the poor adherence that we have in women once they start RT and their poor retention in this cascade of services? Over.
Does anyone have an opinion on that? Joseph, are you on mute?
No.
Oh, okay.
Oh, you're on. All right, all good. The first thing that came to mind for me was specifically access to transportation to clinics. And also just thinking about family dynamics, I think just taking care of a child is already demanding as it is. So having to go and sacrifice time to go to health clinics on top of childcare, who knows how many children they have, it's hard to adhere to kind of all of these programs.
Yeah, you're absolutely right. So one of the main barriers for retention and adherence to the health services is as lack of transportation. Most of the patients live far away from the health facilities. They don't have sufficient money to pay for transport and to go back on time to ART, to the consultation and to pick up the ARVs. When we assess the defaulter rates in Mozambique, we noticed that most of our pregnant and breastfeeding women retention rate at 1 month after ART initiation it's low. It's around 78–80% at 1 month and drops a little bit and increase a little bit at 3 months, but this varies among the different provinces in our country. And when we have the ability to identify the women who are defaulting and implement all the strategies that we prepare to make her return to care, and we have the chance to sit with her and try to find out what was the problem, what she became the defaulter. Most of them refer to the problem of lack of transportation to go back to the health facilities. Another thing that you mentioned is the work at home and work demands, that it's not easy to a woman that it's married, that needs to take care of the family and the other parents that and sometimes when they have someone that is sick, she is in charge of that person to spend time and to go to the health facilities. And the problem is that when she arrives at the health facility, she can stay there or spend most of the day at the health facility. So the waiting time is also high at the health facility. That's another challenge. And that's something that when we had the possibility to talk with these women, they refer to this a lot. And the other thing is the pressure, the stigma, okay, for the family. She is not able to disclose to no one at home, neither to her husband or the mother-in-law or other family members. She is afraid of stigma. She knows that she needs to take the drugs, but she needs to hide the drugs, not only for her, even for the babies. We have lots of stories of women coming back to the health facility and say, please, can you switch the ARVs into a different bottles, maybe put in a bottle of a different medicine that it's more acceptable at the community or it could be more accepted at home, so can I easily be able to provide, to give the drugs to the kids. So we really have lots of stories about that. So the stigma and the lack of disclosure and fear of violence is very high. And because of that, they don't have the support or from the family or from the partner. Another thing that
Inês, I'm going to give you last comment and then we're going to move on. But one more comment.
Okay,
go ahead.
So no, I think you can go ahead. So there is one question in the chat that mentions about HIV prevention programs in school. Just to say that we have HIV prevention programs in school that provide HIV overall health literacy and literacy to HIV. They do counseling for HIV tests, and even some teachers are trained to screen their children and to refer them back to the health facilities to be tested. One thing that we as a country are not offering is the HIV test at the schools. Some countries are moving on with that strategy, but in Mozambique, this is not yet allowed, particularly in primary and secondary level schools. At high schools and in some districts, some secondary schools started to do this work, and we are still working with the ministry to implement more on HIV testing at school. Thank you, Chris.
Thank you, Maria Inês. And you know, you talked about the male partner disclosure, and we showed this graph. In my work, I would estimate that 50% of the babies that I diagnosed with HIV in the hospital, the moms haven't disclosed to the fathers. And you know, it's not normal for a newborn baby to have 2 bottles of syrup that they come home from maternity with, and one they're supposed to take twice a day, and one they're supposed to take once a day, and that raises questions. And so it's impossible to hide this at the home setting. So if there's non-disclosure, it's not going to happen. You know, male partner involvement, I think is key. We often, when we make new diagnoses, we call them and pretend as if it's a new diagnosis for the mom, so that they can get tested as a couple, and the kind of disclosure can happen there as a couple. But we're really behind on that, particularly in the southern part of the country. And now we're going to go, guys, to our last pillar. We have 8 minutes left. So we also have to remember that HIV is a chronic lifelong disease. You know, we don't have a cure right now. And so let's imagine a situation where, you know, we have women who've been HIV positive for a long period of time and have been on antiretroviral treatment, and they choose to become pregnant again, or they become pregnant again without, it could be unplanned as well. This graph shows the distribution of the type of prophylaxis that women were on in the year 2019 by province. And so what the dark green bars are the percentage of women who were already on ART when they became pregnant. And so often there's this thinking that these are all new diagnoses, but remember, these are Mozambican women who live in a culture that values families, and they want to have babies. So we need to make sure that we're providing good chronic care to women living with HIV, so that when they're in the best position to protect their babies. And we have a lot of challenges with chronic HIV care in Mozambique. We talked a little bit about problems with retention in the PMTCT cascade. They're just as bad in the general ART program, where we estimated in 2019 that only 67 patients who were initiated on ART were still in care 12 months later. And this is, you know, a cascade of services that we saw. You guys have heard probably of the 90-90-90 goals, where we want 90% of people to be diagnosed, and 90% to be on treatment, and 90% of them to be suppressed. And you can see here that we had, you know, approximately 73% diagnosed in 2019, only 59% of them on treatment, and then our virologic suppression rates were really low. At this point, we were using an inferior ART regimen, and like I mentioned, we're now using a drug called dolutegravir that we think is improving that. So we're not going to have time today, but it is important to know from the region, and even from examples within Mozambique, that EMT-ACT is possible. There's countries who are neared that kind of classification and WHO give. And we don't have time today, but one of the programs that CDC and Maria Inês support is called Mothers to Mothers, and a lot of you might have heard of them. But they do, you know, several times a day, Maria Inês has talked about the value of the peer mentor model. And this is a program that I think maybe in the last few minutes, Maria Inês can talk about. And then we'll leave the last few minutes to you guys if you have any final questions or comments, okay?
Yes, thank you, Chris. Just quickly to say that I think in 2013 or 14, Mozambique started to implement the mother to mothers activities that was a kind of support group for pregnant and breastfeeding HIV women. But more recently, we bring in the M2M organization, Mother to Mothers organization. It's a South African organization that started to work in Mozambique, and they included in our Mother to Mothers program the peer mentorship support for the pregnant and breastfeeding women and for the exposed infants. And seeing the good impact of this peer mentorship support to improve the attention to the PMTCT services, the reduction of the vertical transmission rate, we also expanded this program to serve the fewer, every time fewer HIV infected infants support up to 10 years old. So this is a program that is evolving. If you get the chance to look at this YouTube video, you will be able to learn a little bit more about that. But I just wanted to finish to talk about the previous photo that Chris showed you with a woman and a child, to say that this is really possible, and more and more we are seeing women getting tested at first ANC consultation, diagnosed HIV positive, started on ART, and have a positive and a negative and healthy child, and they repeat the cycle. So what we are calling is the positive impact of PMTCT in Mozambique. She kept returning to the ANC consultation. She stayed there for 2-3 years. She get pregnant again and again because she is noticing that it is possible to have a negative child and be healthy. So that's the good part of our programs as well. Thank you.
Thanks, Maria Inês. I see a question from Nafisa about depot or long injectable forms of antiretrovirals, and it would be great if those get approvals and get to us. It'll help us overcome a lot of the challenges we have with adherence and stigma. So we're holding out a lot of hope for those, but right now that's not available. So Emily, I'll turn it over to you in case there's any more comments or questions.
Yeah, if anyone has questions, please feel free to drop in the chat or mute yourself, or you can message me. But I'm just monitoring it. But in the meantime, I guess I'll ask a quick question if it's okay. My question has to do with kind of just outside of, like the peer-to-peer programs, and also maybe like expanding like HIV testing, and like some like prevention education. What are some, I guess, effective strategies that can be implemented at least like on a shorter time course that can like kind of bridge that knowledge gap, not only specifically to young populations, but I guess we talked a lot about like kind of like the lack of like male involvement sometimes. And so I was just curious, what are some ways in which education can be expanded to reach like those specific populations?
Maria Inês, you want to tackle that or you want me to try?
You can try, Chris.
Mm-hmm. I think educational interventions and behavioral change interventions are tough. There's been a lot of things that have tried and very few things that have been proven to be efficacious. A lot of times people's behaviors related to sex and the family and are really ingrained and hard to choose. I think for me, one of the things that we're focusing on that is a short-term thing is making our health services more friendly, patient-friendly. So Maria Inês talked about 2 queues and long wait lines, and pharmacies that are only giving 1 month of medicines when they could give 3 months or 6 months to reduce the burden on patients who are already poor and have a lot of competing demands. So for me, that's something that Mozambique, I see Dr. Hoffman on the call, and she's worked in Malawi, and Malawi's been the leader at thinking about things like that and doing multi-month drug dispensing, for example. And Mozambique resisted it for a long time. But for me, why we continue to expand access, promoting, patient-friendly services and comprehensive, that have family planning and education kind of integrated. And then on the long run, we can work on these behavioral change issues, these education issues that are going to take a little bit more time. I saw Joy's hand earlier. Do we have time for one more? I know we're past the hour. Maybe not. Emily, you want to close it up?
Yeah, no, absolutely. So I just wanted to thank you and Dr. De Deus for such a wonderful presentation on PMTCT. It was really, informative and comprehensive. And if anyone has any questions, we can definitely try and distribute contact information. But that's all I have. So thank you again so much for this great presentation, and thank you everyone for coming this early morning.
Thank you, Maria Inês. You were great.
Thank
you.
Thank you, everyone. Have a great day.
Have a great one, everyone. Bye.
Thank you. Bye-bye.